I'm glad you're watching us live on Hangout on Air today. The topic for today is dental record keeping with Duane Tinker. Duane Tinker used to work for the Texas State Board of Dental Examiners. This was a law enforcement agency. Duane was on the other side of the fence for many, many, many years. After seeing a lot of good dentists sanctioned because they did not pay attention to compliance, Duane founded Dental Compliance Specialists. Duane, let me hand the mic over to you. Why don't you first introduce yourself and then tell us a bit about the topic that we'll be talking about today.
Good morning, Noreen. Thanks for having me. I appreciate the opportunity to share with your dentists here. A little bit more about my background here. I spent most of my professional career in law enforcement, and I actually started out chasing bad guys on the street, moved up into working white-collar crime, and ultimately ended up working civil and criminal cases for the State Dental Board. A number of different types of cases ranging from standard of care complaints to infection control problems like we see on the news from time to time. I dealt a lot with insurance fraud and also Medicaid fraud issues as well. So today we're going to talk about the dentist's greatest point of liability and the #1 reason why dentists find themselves sanctioned either by their state dental board or by insurance companies or even Medicaid programs. And some of these sanctions can even result in criminal actions. So it's important that we get it right, and important that we understand and take this clinical record keeping seriously, because it is the most important half of the job that you do for your patients. So let me pull this up real quick here and start at the other end here. Can you see my screen okay, Noreen?
Yes, I can see your screen, Duane.
Okay, just making sure that you're still with me. We're going to talk about the consequences of poor record keeping and also record keeping habits. We'll look at essential components of a dental record, the importance of the accuracy of the consent process, and the steps that should be involved in obtaining consent from your patients. We'll talk about how to create records that will limit your liability, and we'll finish up talking about Tooth Cop's rules of record keeping here, which are my rudimentary rules on how to write your records. So let's see. So the #1 most common problem in dentistry, it is record keeping. It has nothing to do with the clinical care that we provide. And really and truly, your clinical record keeping is a reflection of the care that you provide. So I've met very few clinicians over the years that just aren't just great clinicians. And that being said, times have changed. But I work with a lot of dentists, both older and younger dentists, and I find that really the older dentists seem to have a hard time in the regard that the dental schools don't teach or didn't teach dentists about clinical documentation. The younger guys guys and gals seem to know how to do it, but you get out of school, you get into a dental practice, you start making good money, seeing a lot of patients, complacency kind of sets in, and that's where the problem lies for most younger dentists here. So it's important to keep in mind that clinical record keeping, it's a legal document, and this is not this is not a good time or place to be complacent. Most people are very conscientious about the dentistry that they provide. Uber importante that we give due regard to your documentation. So by definition here, a clinical record, your dental records, they're a chronological communication or record of the communications that you have with your patient over a period of time. It's also a record of your evaluations, your recommendations, and a record of the care that you provide to your patients. And Noreen, if you look at each interaction that you have with a patient as a separate story or separate chapter within a story, what we need providers to do is recognize them and to help tell the story, to get the information from what you know in your head and what you know from your experience translated into your clinical documentation. So we have lots of details here in each encounter, in each story. So we want to know with every patient encounter the who, what, where, when, why, and how, because those details are essential. I mean, no author in the history of ever has been a successful author writing once upon a time and in their next sentence writes, and I live happily ever after. It just doesn't happen that way. So, so your details are very important. Now, here's what can happen when a dentist fails to accurately document the care that they provide, their recommendations, and so on and so forth. You know, not only the insurance, I mean, not only the Medicaid systems, but also the private insurance companies are recognizing that dentists, that they do have a lot of issues with complacency, and that their records, that many dentists do have records, or insufficient records rather, and records that just don't explain the story of what happened with their patients, the doctor's rationale, what their observations are, their recommendations, and even documentation that they actually provided the care that they billed to the insurance company. So I'm not going to read through the whole example here, but you can see on your screen here, this is just one example out of many that I've heard, and the private insurance companies, they're spending millions of dollars investing in computers and software and systems to be able to track a dentist's claim submission and compare dental claims that are submitted by every dentist in your geographic area to identify different outliers in an effort to try and identify who's overutilizing their systems, tapping into their pocketbook more than other dentists. They're also looking for indicators of fraud, waste, and abuse. And oftentimes, just because you get paid for something doesn't mean that that money is righteously yours, and certainly not if you don't do your homework and provide adequate clinical documentation. So you can see by this particular example here that this was a multi-dentist practice, and a common issue that we see is oftentimes the associates will do the work and take care of the patients, but they're not credentialed like the principal dentist is, and because that would be a difference in the reimbursement rate, and also because that when we submit a claim that identifies a billing provider and also identifies the primary principal rather than the actual treating dentist as the treating provider, then those claims become fraudulent claims. So we've got that. We've also, in this example here, we've got some, lost my train of thought here. Let me move on to this next one here. I get calls from dentists all the time that they've got pain. Insurance companies coming in to do an audit. I know where I was going with that last example here. These insurance companies, they're watching a dentist's claims and utilization rates, and when they identify an outlier, this is a situation where they will either send a dentist a letter and say, hey, look, you're submitting too many claims for payment for this particular type of treatment, or they may send representatives from the insurance company to your office to actually audit your records. And this is where dentists are getting caught up, because they've been paid for services that were provided to their patient. The insurance company shows up in the office to audit the record, and maybe they're looking at an overutilization concerning, say, root canals. And they pull up and look at the dentist's records. They may or may not have a diagnostic quality periapical X-ray. Maybe don't have consent for the root canal. Maybe they don't have a written review of medical history or patient's vital signs, or just generally substandard documentation to indicate what the doctor examined to help them arrive at that diagnosis point. There's no actual stated diagnosis, so really we haven't documented why it was necessary to do the root canal. And these insurance companies are identifying that lack of documentation to support why the treatment was necessary, or even that it was necessary in some cases. That's what they call an overpayment. And what they'll do is they'll look at X number of charts, they'll calculate an error rate based on the percentage of errors based on those charts that they reviewed, and they'll come up with a percentage, and they'll apply that percentage of overpayments, and they can go back and apply that error rate to the total number of claims that a dentist submits over a given period of time. And that's how we see providers having to pay back 6 figures to the insurance companies. So this gets much, much scarier when we're dealing with either a state or federally funded healthcare program, such as Medicare, Medicaid, CHIP, and a number of other government programs. In this next example here, I had a dentist call me about 6 months ago. Had Medicaid come out to his office about 2009, and they pulled a sample survey of 51 charts. They reviewed those 51 charts, and they found a number of mistakes there. And you know, unfortunately, when those mistakes, whether they're intentional or not, they're all lumped under this umbrella of fraud. And those also opened the dentist up to liability for the submission of fraudulent claims. That's why we find a lot of dentists that find themselves in trouble after a retrospective review for fraud, waste, and abuse of either insurance program or with a federally funded program here. So just a quick word to the wise here, whether you're dealing with a private insurance company or you're dealing with an audit from Medicaid, when they show up to do an audit, they give you a very short window of time to, unless they're in your office, they can do a desk review and require that you submit to them those 50 or 100 charts. And it's important that you make those deadlines, because if you fail to make and submit all 100 records as they describe within that short window of time, which is usually less than 48 hours, if you fail to meet that, then you will lose your right to appeal any findings that they find against you, and you can be on the hook for whatever they determine as your liability. And you can certainly lawyer up, get an attorney or a team of attorneys, but that's really expensive, for one, and two, there's no chance, there's no guarantee that you'll make any headway at all. So important to pay attention to that. With this particular case here, with this dentist that had those 51 charts pulled by Medicaid, they went back and they identified a number of different issues here. Like some cases, there was no consents signed by either the patient or the guardian. There was just insufficient documentation in some cases to support that the treatment was either needed, or in some cases that it was provided. Now again, this is they're looking at mistakes here. So in some cases, maybe the dentist, maybe they mistakenly billed out for 4-bite wings and 2 PAs, or maybe they billed out for fluoride because they provided it, but somebody failed to document that they provided the fluoride in the clinical note. In some cases here, the dentist did not have any narratives whatsoever. I see this a lot in a lot of dental offices, believe it or not, and sometimes it's a routine practice, and sometimes it's just somebody didn't go back and catch that the doctor or the dental assistant failed to input any clinical notes. So this is really, really important. In fewer and fewer cases here, I'm seeing issues with improper coding. Most dental practices bill and code for the same few types of procedures over and over and over. So I don't see too terribly many issues with that here, at least in the last several months. In this sample of 51 charts, there were 2 patients that didn't have any record whatsoever. So I don't know if they were misplaced, if the files were corrupted, or what happened here. And then we've got some situations here where the treatment date and the billing dates didn't match. The billing date should always reflect the actual date of treatment. One word to the wise here, I'm aware that there's a number of consultants out there that are encouraging dentists to increase their profitability with regard to their hygiene departments and scaling and root planing by doing 4 quads of scaling and root planing, but then billing it out 1 sextant at a time over subsequent days or different billing periods, or billing dates rather, which is fraudulent. So for those that are doing that, I encourage you to kind of revisit that issue and see if that's really in your best interest to do that. Another issue here was work that was being billed, identifying the principal dentist as the performing provider. Again, that's not what actually happened here, so that would make that a false claim. And there were also a number of ortho cases that were being scrutinized here, and that's a whole other animal that I'm not going to deal with here. So, with regard to this sample survey, though, they reviewed 51 charts, and from that, the state went back to this provider and said, "Look, we found a number of errors here in the amount of $61,500 or almost $600 here, and we're going to apply that rate based on whatever percentage they came up with off those 51 charts to the total number of claims that that provider submitted over that same period of time from which they took those records. So I don't know if that was like a 1 year or a 5 year period of time, and frankly I just don't have any idea of that information. But when we're talking about a federally funded program here, Medicaid and CHIP, Medicare, under the False Claims Act, when the government goes back to take money back on an overpayment from a provider, they can assess civil monetary penalties, which includes repayment of up to 3 times the amount of the claim, plus fines and penalties up to $11,000 per claim. Now, it doesn't take much to add up to a very large amount of money. Well, for one example here, 50 claims submitted for $50 a piece. If you had to pay that back, is what, $150,000? No, 25. Oh, shoot. Well, anyway, I'm trying to do mental math here and it's not working out real well. Anyway, 50 claims at $50 a piece, multiplied by 3, then you go back and you add your fines and penalties up to $11,000 per claim. We're up or somewhere around $550,000 worth of reimbursements. Now, to many dentists, that represents, you know, a pretty sizable chunk of their financial nest egg right out of their retirement. So, you know, this can add up very quickly and get very, very ugly in a very short amount of time. Here's an example here of some clinical records that I see, and unfortunately, I see this all too often, and this really, really concerns me. You can see the dentist notes here: comp exam, 2 BWs, panel. It doesn't tell us a whole lot of information here, but the next document that I see in reviewing this record is, you know, a number of pulps and SSCs, a recommended extraction, and some sealants. Well, so I really don't see any information that explains in the record here how the dentist got from point A to point B, point A being the exam notes, point D being the treatment plan, and then the doctor indicated that all the planned treatment was completed, and then the doctor wrote a prescription. So, well, let's talk real quickly about what information is missing, because what's missing is really critical here. Most states, it's standard of care that you document a written review of the patient's medical history, that you accurately and thoroughly and in a detailed manner, that you document what was examined, what your findings are from what you examined, and then how you verified your observations. You know, the presence of caries, was it viewable radiographically? If not, was it viewable clinically? You know, did you verify with an explorer? Things like that. What did you do? How did you determine what the patient's problem was? Did you state what the patient's problem was, etc., etc.? Another thing here is, you know, dentists are reimbursed not only for taking X-rays, but for the dentist's interpretation of the X-rays. I would make sure that your clinical documentation specifies that you reviewed the X-rays that were taken on the date that you took the X-rays, or at some reasonable point in time afterward. You know, just to document the patient's caries or to document the patient's problem in a tooth chart kind of implies that you read the X-ray, but if you didn't clearly and specifically state what you did, you didn't do it. Let's see here. So here's some more information that's missing here. How were any of these recommended treatments necessary? What did the doctor examine that helped them determine that it was necessary to do a pulp and SSC on this patient here? Was any anesthesia provided to this patient here? You know, I'm not a dentist, I'm not a clinician here, but, you know, as a lay person, when I see a dentist do that much treatment here and there's no indication about any anesthesia, whether it's local or otherwise, you know, a big red flag comes up in my mind, and I'm thinking it probably comes up in your mind as well. You know, how are these claims for the pulps and SSCs and extractions? Where's the clinical documentation here to support how they were necessary? And there's no discussion here about the consent. You know, was mom or dad present? I'm assuming this was a pediatric patient. You know, was mom or dad present? Did somebody review, have that discussion with mom or dad about the consent process, which we'll talk about in just a minute here, et cetera, et cetera. So here's an example. Now, I'm not going to say that this is a perfect clinical note, but I think this is a whole lot more substantial than what we saw in the last couple of slides here. The patient presented with a problem. I reviewed the patient's medical history. There was no significant finding in their medical history. I orally examined the patient. I verified presence of caries. I took an X-ray, which verified the presence of caries, and made a clear diagnosis. The patient has caries of number 3. The plan for this patient is to, excavate and fill this cavity. We have very specific documentation here about the consent process, which we'll talk about in just a moment. So we're not only documenting in our clinical, or we're not only completing the consent form, but we're also tying that form in. We're entering that form into evidence, if you will, just like if you've ever seen a good lawyer show on TV. When they're in court, they always want to enter a piece of evidence into into the record. We really want to tie that record in with our clinical notes here. We're describing how we provided the procedure. This second bullet point here, caries and preparation extended into dentin. It is important to show that why it was necessary to reimburse a dentist for a filling instead of a lesser type of treatment. We're demonstrating that medical necessity for the filling. And then we document here our post-op instructions. Again, details are important. The very last part that I want to point out here that's really, really important as well is a doctor's or dentist's signature at the end of their treatment notes here. Dentists ask me all the time here, hey, am I allowed to have my staff complete my clinical charting? And the answer to that is absolutely, but do know that you're on the hook. They're your notes. It's your patient. As the treating dentist, you're responsible for those notes. So it's important that you go back and review the notes and make sure that they are accurate, and also to continually retrain with your staff to make sure that they understand how to write their clinical notes in a way that reflects what information that is accurate and correct, and also reflects the information that you require, and always follow that up with a signature. So let's see. I came up with after looking at just hundreds and hundreds of records here, and finding all these different problems, I came up with 6 short rules to help dentists, give some guidance to dentists and their staff with regard to clinical record keeping. Number 1, I can't emphasize this enough. I've had conversations with a number of dentists that have lost their license and have gone to prison for, Medicaid fraud, and those dentists have all told me, I just didn't supervise my staff as well as I should have, and I didn't do anything wrong except that I just didn't document enough, and that was their downfall. So that was really interesting to me. So number 1 is, if it's not written down, it didn't happen, and it wasn't discussed. You have one opportunity to tell your story with any credibility about what happened with a particular patient at a particular time at some point in history, and the best time to tell that story is at or before the time the patient leaves your dental chair. To describe a problem that a patient has or a concern that they express to you, it's best to describe that in your clinical note at the time that it happens. If you wait until a patient files a complaint with your state dental board, or they file a lawsuit against you, or they file a claim with the Better Business Bureau, or peer review, or any other mechanism that they have, anything you document after they file the complaint, the courts typically look at that as you're documenting a series of excuses. Whereas if you would have documented that at the time that it occurred, they would have looked at that as an explanation of what happened, and that would have given that a whole lot greater weight or credibility. So, when you encounter a situation here, rule number 2 is, when in doubt, write it out. If you're asking yourself if something is clinically relevant, is it really necessary for you to document certain information, like your patient won their basketball game, or grandma got run over by a reindeer, or something crazy like that? Is it clinically relevant? Heck no. But the fact of the matter is, it shows that you're paying attention to your patient. And for you to document that kind of detail about your patient, it tends to add an extra measure of reliability to the record that the rest of the information is probably pretty detailed and pretty accurate and pretty much correct. You can never write too much. Your clinical record keeping, it's there for you to jog your memory at some point down the road. The fact of the matter is, regardless of whether you're a young dentist or an old dentist, we're all aging, and some of us a little more gracefully than others. And at some point in time, we all suffer from what they call CRS, where you can't remember squat. So if a patient files a complaint, maybe it's 2 years down the road, maybe it's 4 or even 5 years down the road that you have to go back and recall a specific incident in detail in front of a jury, in front of a board of your peers at your state dental board, or some sort of civil action in a JP court or something. The amount of documentation that you have needs to be enough to help you remember what happened with a particular patient at a particular time. So you can never write too much, and for those of you that need a lot of detailed notes, there's a number of different services out there. You can either use a transcription service. There's Dragon Dictation has a medical version. Also, some dental softwares have a component that you can transcribe and speak your notes into the record, and it'll automatically transcribe for you. So there's certainly some options out there for you to consider. Be objective with your notations, and remember, you're dentists, you're not psychiatrists or psychologists. Be careful documenting when you have difficult patients and saying that your patients are crazy, or that you have a patient that's a PIA. To document a patient that is a pain in the tush, it's great to document that, but keep that in a separate journal, completely away from your clinical records, so that there's no relationship between your clinical notes and your personal ramblings or feelings about your patients. Okay, any information that's documented in your patient record, that you're liable for that. And when we get into talking about HIPAA regulations here, as you're familiar with that, your patients have a right to access the entire dental record that you have at any point in time, and they can access the entire record, your clinical notes, your financial records, your x-rays, the comments that you make that are in the patient record. So be careful about the notations that you use. Number 5 here is be timely with your clinical documentation. If you close your office at 5 o'clock, at 4:59, before your office manager hits the send button to submit all the claims for all the work that you provided that day, somebody needs to go back and look through each chart to make sure, do a quick audit. Make sure that you have clinical notes, that the x-rays that you have, the number matches what you're billing, and somebody should check those periodically, check your x-rays to make sure that you have good diagnostic quality x-rays. If they're not good diagnostic quality x-rays, then don't bill them. But point being, make sure that everything that we've done for today is supported before we go home, rather than wait until we go home, or rather than wait until the next day to come back in and do your notes. I love using clinical charting templates to help document very quickly a lot of detailed information, but the biggest concern I have about that is it's very easy for us to document information that's not correct. Many dental offices have established their templates, which have all kinds of great information, but if a template reads that you took 4 bite wings and 2 PAs, but for whatever reason, maybe you only got 3 diagnostic quality bite wings, or maybe it's a pediatric patient and you only took 2 bite wings and 2 PAs. For you to fail to go back and correct and modify the template to account for what actually happened, that would be a fraudulent note. And though it's not intentional, it's fraudulent in the fact that it's not correct. So the standard that we need to strive for is perfection, and recognizing that we're human beings, we're not perfect. But with the political environment that we're in, with the government and the insurance companies watching and scrutinizing dentists like we've never experienced before, to have a standard that is less than perfect, really sets us up for failure. So we've got to have a high standard. We've got to have a mechanism in place to go back and check our work to make sure that we're doing a good job. So when a patient walks out the door, somebody at the front desk should be checking to make sure that we have clinical notes, that we have treatment plan, or that we have a treatment plan, we have signed consent for treatment for that day's treatment, and then whatever we bill out. Well, in a nutshell, all 4 of these documents need to match up, and clinical notes, treatment plans, consent, and your billing. If there's any deviation there, maybe the treatment plan indicates that we're doing a multi-surface restoration, but the doctor opens the tooth and ends up doing pulpotomy, pulpectomy, some sort of endo procedure, or maybe they end up just extracting a tooth. there's got to be some explanation there how we went, why the treatment plan changed, or why the treatment plan changed from the treatment plan, and what information caused you to make that change. Doctors, you know the information. We just need to get it from your head to your documentation to support that change in treatment there, and also to account for why there was a deviation from these 4 documents. Let's see, slide right on ahead here. I talked a little bit ago about overpayments here, and those overpayments are include, double billing. I looked at a record the other day where we accidentally double billed a prophy, and that, to make a mistake like that is one thing, but and to catch that is important. But when we make mistakes like that and we don't catch it, we're liable for that as an overpayment. Billing for services that we don't actually do. Like I said, I look at a lot of hygiene notes, and sometimes the hygienist forgets to document that they actually provided the fluoride, but they bill it out. Look, if we don't have documentation, if we don't have documentation or some sort of proof that we did it, there's just nothing there to support us. Lack of medical necessity. It's important to indicate why we did a root canal, or why we did, why we took a child to some sort of sedation. Documenting the child's behavior, the child's risk factors, to show why it was necessary, why it was compassionate care and appropriate for that patient, to justify that we did it, and also to justify getting reimbursed for it. And then I don't have a whole lot of time here to talk about excluded persons, but for those that do participate in federally funded programs, it's important that you check to make sure that your staff are not excluded from being able to participate, and for you to benefit or receive money from the Medicaid program by having an excluded employee on your staff. So it's important. I mentioned before, it's important that you put a mechanism in place here to periodically check some of your charts, to make sure that they are correct, to make sure that you have everything that you billed for. And when you find a problem, it's important that you correct the problem. Sometimes that might be, going back and having your dentist, whoever you or your associate, to go back and modify your note if you remember what actually happened, and it's got to be accurate. We don't ever backdate anything, but go back and correct the note if that's what it takes, or submit a corrected claim, send that money back to the third-party payer. When we're talking about the federally funded programs here, you've got a 60-day period from the time that you identify an overpayment to correct that problem, to send that money back. And if you don't, after that 60 days grace period, you can incur penalties under the False Claims Act, which we talked about before, is up to 3 times the amount of the claim, plus fines and penalties up to $11,000 per claim. So the next question I get is, well, Tink, if we got 60 days to, send money back or to make a correction after we identify a problem, well, why bother identifying a problem so we don't open that window? Well, the government's expectation here, whether you're in, whether you're dealing with private insurance or with the federally funded program, the expectation of the federal government is that you do police yourself, and you do attempt to uncover your own mistakes and correct your own mistakes. And what we've seen in recent years is for those that try and turn a blind eye to their operation, that fail to respond appropriately and fail to correct their mistakes, that when you get caught, they're going to throw the book at you. Well, let's shift a little bit, talk about consent for treatment here. Consent in many states is actually defined as standard of care. It's a record-keeping requirement, but it's also defined as standard of care. And those consent forms have to give the patient enough information to arrive at a reasonable decision point to either give or withhold consent for treatment. So the consent forms should give enough information to help explain to a patient what the procedure is, what the benefits of treatment are, what the reasonable alternative treatments are, and also the risks and complications or potential risks and complications of a given treatment. And there should also be that documented fee discussion, either on the consent form or make sure that you review and have the patients sign the consent plan, or the treatment plans, rather. Once upon a time, there was this concept of verbal consent, and I'm not a fan of verbal consent at all. If you go back and look at our rule number 1 here, if it's not written, it didn't happen, it wasn't discussed. Whole cases in court and also in front of state dental boards are won and lost by dentists because of consent and proper handling of the consent process and having or not having proper consent forms. Not only do you want to have a consent form, but you should also, like I mentioned earlier, tie that record in and notate in your clinical discussion who you had that discussion about the benefits, alternatives, risks and complications and fees, who you had that conversation with, that they had the opportunity to ask questions and that you answered their questions and that they ultimately chose or decided to go with the treatment that you recommended, and then reference that they did sign the consent form. So make sure you understand who can consent. Different states have different regulations. Texas is 18. Many states are 18. South Carolina, I think, is for a person to be able to make their own treatment decisions is 16. So most states, regardless of what their age of consent is, they have certain exceptions to that, and it's important that you understand what those regulations are for your state. I'm going to skip over this part here since we just talked about what information is necessary on a consent form. But one thing I do want to point out is one of the Jayco standards. For those dentists that have hospital privileges, you're probably familiar with this. The Jayco standard before you do surgery in a hospital setting is you've got to do a timeout procedure, where you literally take a timeout before you pick up your scalpel and start surgery, and you review with your staff, with the patient, that you've got the right patient, you've got the right treatment, it's the right time, and you've got righteous consent for the treatments that you're about to provide. And then, if you haven't already, make sure that you, as the provider, make sure that you also sign the consent form and make sure that that form is filled out correctly. So, if you're going to delegate having the consent process to your staff, you're the one that's going to have to answer for any mistakes. My suggestion would be, as a part of your timeout process, make sure you personally review that form, sign off on it, so that you know that you've got consent for treatment. Sometimes we may have to use multiple consent forms. If that's the case, then so be it. I would definitely use isolated, separate consent forms for any sort of immobilization or behavior techniques, and certainly so for any type of sedation, including nitrous administration, enteral sedation, IV sedation, and certainly for general anesthesia. So let's see. Diagnosis here. Look, you review a patient. You examine a patient. You do your intraoral and extraoral examination. You review the X-rays. A plus B plus C equals what the patient's diagnosis is. In the 2014 and beyond, more states are incorporating the use of diagnostic codes. And it's important, doctors, that you very clearly and specifically state what the patient's diagnosis, what their problem is, so that your billing staff will accurately select the proper diagnosis code to make sure that you get proper reimbursement for the care that you provide. Medical history forms, I'm going to gloss over this real quickly so we can wrap up here. Medical history should be reviewed with your patient pretty much anytime you handle a patient or you touch a patient clinically. Anytime you place your fingers in a patient's mouth, make sure you document their vital signs and also their medical history beforehand. Comprehensive oral examination here should always include, lots of details. A review of your patient's medical history, documentation of their prior restorations, their current oral health status, detailed exam findings and risk factors that risk factors that place them in either a high, low, or medium caries risk index, a person's behavior, oral health status, etc. So, for when providers make mistakes, and I work with a lot of providers that, a lot of dentists, and I find that most dentists they're perfectionists, and they hate to make mistakes, and they certainly don't want to call out attention to the fact that they made a mistake. One of the worst things that we can do, or one of the worst things you can do as a provider when you make a mistake, is to just let it stand. Look, if you know information that in your record is incorrect, maybe you made a mistake, go back and correct it. Don't sweep it under the rug. And you know what? It looks better for you to go back and correct a mistake than it would be for you to let incorrect information stand in your record and then for you to have to answer for it later on. So, hey, it is what it is. If we make a mistake, let's go back and take care of it. Go back and quote the information that's incorrect in a new note on a new date, and you can reference that the note was from a previous date, and just document what the incorrect information is, and what the correct information should read, and there you have it. So let's see. I'm going to skip through some of this clinical document, or this handling this sedation records here, and just know that for those that do provide sedation services, DEA requirements are a little bit different than your state board requirements. Not only do you need to document the dose, the amount, the type of drug that you administer to your patients, but you also need to keep a central drug log to account for each drug that you dispense, how much, when, that it was for a legitimate dental purpose, and so on. In a nutshell, you should have a separate form, a separate entry, a separate ledger for each drug and each concentration of each drug. And if you track your drugs, your total dose on hand, just as though you would track your a checking account, all the money in, all the money out, same thing with your drugs, so that you can see on hand the total dose that you have. You're required under DEA regulations, if you have or use controlled drugs in your office, to document a physical inventory of your drugs every 2 years. If you're tracking your dose on hand, it provides accountability so you can account for your drugs and know that there's no theft of your medicines. And also it helps to facilitate when you have to do that inventory of your drugs. So go back to this picture here. From an enforcement standpoint, this looks like a party. This was a tray set up in a employee break room. You know, if I walked in and saw that as an investigator, this dentist would be in a lot of trouble here. I mean, he's got his Dixie cups out, a couple of syringes. I mean, these are controlled drugs. They have to be locked up when between uses. So make sure you handle those and document your dispensations accordingly. I think we're gonna go ahead and open it up here to questions here. If anybody has any questions after the call here, you're welcome to give us a call. We can set up a time to do a consult and just talk about your concerns, figure out where you're at and where we need to go to help you to protect your practice. So, Nareen, I'll turn it back over to you, and we take some questions here.
Hi, Duane. Yes, I do have a few questions from dentists. Let me start with the very first one.
Okay.
You know, one of the questions that kept coming was, you know, a lot of dentists believe less is more, right? And they were asking if, when it comes to record keeping, that kind of a philosophy, would it work? What are your thoughts on it?
You know, I hear that every now and again, that less is more philosophy. And, you know, I've never seen a dentist lose a lawsuit or even end up in prison, for that matter, for documenting too much. But I frequently see the opposite. So I don't subscribe to that. Definitely not. More details, the more the merrier.
Listening to your presentation, it seems to me like you're talking about needed treatment. What about cosmetic dentistry, right? Because cosmetic is not needed, rather people choose to have it.
Yeah.
Would you recommend doing it differently? What are the differences?
Well, the difference is, since it's not clinically necessary, but it's something that's elective. You know, for those that do cosmetic dentistry, you know, oftentimes when a patient's not happy, you know, they file lawsuits, they file complaints, and it's important that you document, you know, that the patient, whether the patient was satisfied with the result at the time that the care was provided. You know, the fact that they approved the shade, or they approved the shape, or the look, or the feel of the care, that the appliance or the treatment that you provide, and with as much detail as any other type of record, because you know, you do tend to have a higher liability, you know, because of the higher likelihood of having an unhappy patient.
So if I were to understand what you're saying, is that regardless of whether it's you know, cosmetic or any other type of treatment, you know, documentation is good in all cases, and you should follow stringent standards.
Absolutely. I mean, whether you're doing a cosmetic case or a restorative case, your state board standard of care, they require that you document your review of medical history, that you have consent, that you know, in some cases that you document the patient's vital signs, and so the standard isn't any different for cosmetic dentistry. So yeah.
Makes sense. My next question is about electronic signatures. Are they legal? What are your thoughts on it?
You know, they use those every day in our judicial system, in our state and federal courts, and you know, I understand that the few challenges that they've had in the court system, that judges have ruled in favor of you know, and allowed electronic signatures. So I think they're fine. And there's a lot of dental practices, more and more dental practices that are using some sort of signature pad to get their patient consents and things like that. So the key is to make sure that you've got a good capture and make sure that that you've got your data backed up.
Right. So is this something they should check with the local dental board, or is this something that you are suggesting that anybody in the U.S. can do?
No, I think electronic signatures are fine. I mean, every state, all 50 states' court systems use electronic signatures, so that I think there's enough case history there from a legal perspective that I don't have any concerns about dentists using electronic signatures.
Makes sense. How long should a dentist keep his or her records? I know you talked about backing up. So how many years do you think they should keep it?
Well, different state boards have different rules and regulations. First and foremost, though, I would say check with your liability insurance carrier and find out what their preference would be. There's some carriers out there that would prefer the dentist keep their dental records for every patient indefinitely, so that they're the ones that would have to defend you in a standard care complaint and some sort of professional allegation. So ultimately, you want to do what your provider would prefer. Other than that, if they don't have a preference, then contact your state board. Most state boards require at least 5 years. There's some HIPAA requirements that require that you keep those for 6. Some states require that for your pediatric patients that you keep your records for 3 or 5 years after your patient's 18th birthday. So the good source would be first to check with your insurance and then your state board.
Makes sense. What are the differences between Medicaid, DMO, PPO, and private pay patients? Are there any differences when it comes to record keeping?
No, it's just like with the difference between regular patient or a restorative case and a cosmetic case. The standard of care isn't any different with regard to documentation, and that documentation requirements are certainly the same. And you've got to have your consents. You've got to have some indication of who wrote your clinical notes. Who made an entry in your record. There really is no difference as far as the detail that you need to have.
Now, I have another question that came both from people running large practices as well as small practices, and the question is, how do you make sure things are happening? How do you make sure that record-keeping issues are not propping up? Are there any best practices? Are there any suggestions you have? I mean, let's say on one case, somebody with a 40-staff practice and somebody with a 3-person practice.
Yeah, that's a really good question, Noreen. You've really got to build a system of checks and balances in place. You need to, whether you're a small practice or a large practice, you need to have some mechanism to, go back and check your work, just like a teacher will go back and check their students. Except in this case, you're going to have to go back and check your own work if you're in a small practice. Pull a sample of your records. 2 records a week, 10 records a month, something like that. Get out your record, you and your staff, go through the record, make sure that you have all the information that you need. Verify, what I usually do is print out the financial ledger to show all the services provided, and I go back and I compare that financial ledger against the clinical notes, against the treatment plan, verify to make sure that whatever we build out as far as x-rays, that we actually have good x-rays. And you can do that, and I would certainly keep a record of those chart audits that you do. If you're, and keep those record audits over a period of time. We don't want to show a history that we're auditing only good charts or that we're auditing only bad charts. Just grab a random selection of your charts, not just your sedation cases either. Grab some of your hygiene charts. Grab some from PPOs. Grab a couple of Medicaid charts. Grab a good, just random selection of charts periodically, audit your records, and keep a record. When you find a mistake, make sure you go back and address the mistake, and then document somewhere that you've corrected the mistake. If you're in a large practice environment or you have a multiple office organization, really it would be easy to justify having a full-time compliance person whose sole responsibility is watching over your organization for your organization's compliance with all state and federal regulations, and then in their downtime they can audit charts all day long to help catch, identify, and correct mistakes that happen. to help us meet that perfect standard.
Duane, can you maybe show us a slide with your contact information? I'm going to read it out to people because I'm sure there'll be more questions that people have that they would want you to answer. So the information I have for Duane is Duane, D-U-A-N-E, at DuaneCompliance.com. Obviously, the best place to find him is just to go to dentalcompliance.com. I'm sorry, I need to redo the email. Email is Duane at dentalcompliance.com. And the website is dentalcompliance.com. And the phone number is 1-888-994-4744. 1-888-994-4744. So, Duane, you don't mind if people reach out to you and ask you questions?
I really don't. This is exactly what we're here for, is to be a resource for the dental community, and I want people to know that they have a place that they can go. And if you have a question for your state board that you're not comfortable going to, and I get that a lot, call me and I'll be glad to dig into it. Then I'll go to your state board and ask for you. That way you don't have to worry about putting yourself on that proverbial radar. So.
Makes sense. Thank you very much, Duane. So you can reach Duane through his website or his email or his phone number, which is on the screen. So we appreciate your time, and thank you very much, everyone. And thank you, Duane.
Yeah, absolutely. Thank you, Noreen. I appreciate the opportunity.